Hi, students. Hello from another continent. Um, Today we are going to be learning about congenital anomalies of the female pelvis. This is a super interesting topic, and it's kind of fun to learn about, so I'm excited to teach you, and I'm excited for you to learn a bunch of new stuff about the uterus. So think about one thing that you've learned from the online content. There was something super interesting, or something that you maybe want to keep in the back of your mind for when you go to clinical. It's all good information to remember. So when we're talking about congenital anomalies of the female pelvis, we have to first talk about some terms that relate to these anomalies. So we're going to talk about those first. So hematokopos. So hemato we know means blood, and then kopos means vagina. So a collection of menstrual blood in the vagina. So this happens when there's an obstruction that doesn't allow the fluid or the blood to exit the vagina. So this is a sagittal transabdominal image of the uterus. So we have the uterine body up here, and then we can see the echogenic endometrium in the middle. And then instead of that normal echogenic line sandwiched by the hypoechoic lines for the that we normally see the vagina looking, you can see that it's very much full of a fluid here. So blood is more echogenic than regular fluid, so it's not anechoic. Blood is thicker than water, so there are more red blood cells for the sound to bounce off of, causing the fluid to be echogenic and not anechoic. So that's how we can tell the difference between a cystic fluid and a fluid that's blood. So this is a sagittal transvaginal image of a uterus. So we have the uterine fundus and body up here. We can see the echogenic endometrium in the middle. And then we can actually see the external os of the cervix. So this is something that we don't see very often unless someone's pregnant. But since we have some fluid outlining it, we can see that. So we can see one lip of the cervix here, and the other one comes down here. So this kind of dip in the middle, right in here, that is the external os of the cervix. So if someone were to be pregnant and the baby was being born, this would open up and allow the baby to come through the vaginal canal. But up here, this is the vagina, and we can see that it's full of fluid. So it's not perfectly anechoic. It does have some echoes in it, so we can tell that that's blood and not a cystic watery fluid. When looking at hematokopos transvaginally, it's not quite as good of an interrogation as a transabdominal. Your transvaginal probe is within the vagina, so you're going to be past some of that fluid when you insert the probe, so you won't see all of it. So transabdominal is the best way to take a look at hematokopos. So hematometra. So again, hemato means blood, and metra means uterus. So collection of the blood, collection of menstrual blood within the uterine cavity. So this is a sagittal transvaginal uterus. So we have the cervix coming down this way, and then out into the fundus of the uterus. So instead of that typical echogenic line we see as the endometrium, we can see that it's full of fluid. So this is the endocervical canal, so it's got a little bit of fluid in there, and then as it gets to the body and the fundus, we can see it opens right up, and there's a bunch of echogenic debris within that fluid. So we know that is blood and not watery cystic secretions. So this is hematometra. So hematometrocopos, so we just add them all together. So blood within the uterus and vagina. So this is a sagittal transabdominal image of the uterus. So we can see the uterine body here, and then extending out to the vagina. So again, we can see a very large collection of fluid within the vaginal canal. It's got those echoes in it, not super anechoic. You can compare this fluid to the fluid within the bladder. This is nice and anechoic here. We know that that's a watery fluid. And then we can see all those echoes in here. We know that that is blood. And there's also some fluid collection within the uterus. So that is also blood because we have some echoes in there. So hematometrocopos is the collection of blood within the uterus and vagina. So like we were just saying, the difference between blood and a cystic watery secretion is their echogenicity. So this is a right ovary. We can see right here that Stenographer annotated that. And we have a cyst. So nice black anechoic structure. We have that through transmission we were talking about, posterior enhancement. So it's brighter behind the structure. So that clues us in that this is fluid-filled or cystic-filled. And then we have another ovarian cyst, but we can tell that this looks a little bit different. So we have those echoes within the fluid. So since it's not completely anechoic, we can tell that that is blood. So moving on to a different secretion of fluid, so hydrometra. So hydro meaning water, and then metra again meaning uterus. So collection of watery fluid within the uterine cavity. So we know that cystic watery fluid is anechoic. So this is a sagittal transvaginal image of the uterus. This person's uterus is retroflexed. So we have the cervix coming this way, and then the uterus flips back this way. We can see the fundus out here. So these green arrows are all pointing to the fluid collection within the endometrial cavity. So mostly anechoic here. We have a couple echoes in there. That's probably just a little bit of debris from the endometrial canal, but mostly anechoic, so we know that this is a watery cystic fluid. So other words to know, you're gonna run into these a lot when you are working or in clinical. These are going to be on your orders for ultrasounds. You're going to have to know these terms when presenting a case to the radiologist or writing up a worksheet. So they're great to know now. As you can see, there's a star in the corner, so these are definitely highly likely to be seen on your board exams. So primary amenorrhea. So menstrual period has not begun by age 16. Secondary amenorrhea, absence of menstrual periods for 3 consecutive cycles or a time period of more than 6 months in a woman who was previously menstruating. So primary amenorrhea is someone who's never had a period. Amenorrhea meaning no menstruation. And then secondary amenorrhea is someone who's had a period but it just has stopped for a period of time. Oligoamenorrhea, abnormally light or infrequent menstruation. And polyamenorrhea, opposite, frequent irregular periods. These terms here are extremely important. I should have put 2 stars over here. So metrorrhagia, abnormal bleeding from the uterus. This can be used in a lot of different situations. Menorrhagia, abnormal heavy bleeding at menstruation. So this is a patient who has periods at the correct time frame, so every 28 days, but their period is extremely heavy, when it's happening. Menometrorrhagia, prolonged or excessive irregular bleeding that occurs more frequently than normal. So this is a patient who does not have a normal cycle. So their periods could be weeks long. They could have a period every other week. And when they do have their period, they have extremely heavy bleeding. And dysmenorrhea, that is painful menstruation. All right, so we're going to move on. So now that we've gotten those terms out of the way, we can start talking about congenital anomalies. So we're going to start with the vagina. So vaginal septum is what we're going to talk about first. So a vaginal septum can be present if the Mullerian ducts don't fuse properly. So if we remember from embryology and the development of the female genitourinary system, we know that the uterus and vagina come from those Mullerian ducts that fuse together. So a septum in the vagina can either be longitudinal or transverse. So this would be a longitudinal septum. So it almost looks like there are two vaginal canals here. And then a transverse septum goes across this way, so blocking the exit. So this is the type of obstruction that causes those backups of fluid and menstrual blood. So the hematometra, hematocopos, hydrometra. Blood is, if we're talking about hemato, blood is excreted from the endocavity during the period, sloughs off. It would normally exit all the way out through the vaginal opening, but if it was to hit a transverse septum, it wouldn't go anywhere. So it would just back up into the uterus and cause those conditions. A transverse vaginal septum and imperforate hymen have the same outcome. So an imperforate hymen is very similar to a transverse septum as it blocks the excretion of blood and fluid. So hematocopos is seen with a vaginal septum that's transverse or an imperforate hymen. Hematometra if the septum is high enough as well. If the patient presents with primary amenorrhea, the provider might suspect a blockage of some sort and investigate further. So if we remember, primary amenorrhea is someone who's never had a period before. So this is a normal uterus. This is a sagittal transabdominal image. So we have the nice full bladder, so properly prepped up over the fundus of the uterus. So we have the nice normal vaginal canal leading to the cervix and then the body and fundus of the uterus. And then we have the echogenic stripe in the middle, the endometrium. So this is a patient who has a vaginal septum, and this is their vagina on a sagittal transabdominal image. So we have hematometra. So there's a blockage somewhere in the vagina that's causing menstrual blood to back up into the vaginal canal because there is no exit. So we can see a giant open vaginal canal, and then we have that fluid with echoes in it there, so we know that that's blood and not water. Another case, a patient with a vaginal septum. So the septum is probably very high in the vagina near the cervix because you can see the cervix here, and it extends out into the fundus of the uterus here. So that is normal. And then we have this wide opened vaginal canal, again, full of that echogenic material there. So blood and not fluid. So hematocopos. This is a transverse transabdominal image. So this is a patient who has both hematometra and hematocropals. So hematometrocopals. Excuse me. So we can see that there is a lot of fluid within this cavity here. This happens to be the uterus. So you can see the tissue along the edge here. And then we can see a bit of blood extending into the vagina. All right, so an imperforate hymen. So like we were talking about before, an imperforate hymen is kind of like a transverse septum in the way that it blocks secretions of blood from menstruation. So this is something that everyone is born with that tends to rupture before menstruation, but in some patients it doesn't. So it's seen kind of low within the vagina. So that can cause hematometra and hematocopals. So like in this image, so we have the vagina full of fluid and then the uterus full of fluid there as well. All right, so we're going to move on. So we're going to talk about anomalies of the uterus that have to do with the Mullerian ducts and them not developing properly. So we're going to start with what's called a unicornuate uterus. So a unicornuate uterus is complete or incomplete failure of one Mullerian duct to elongate, whereas the other duct develops normally. So normally you would have one horn of the uterus out this way, so that leads to the fallopian tube, in this case on the left side, and then a normal uterus would have another one on the other side. So you can see a unicornuate uterus is missing that other side of the horn, so we just have the one horn here. A unicornuate uterus is most often associated with what we call a rudimentary horn on the other side. So almost just like a little nub of uterine tissue over there that never developed. Depending on how developed this uterine horn is, it may have functional endometrial tissue. It may not. It just all depends on the severity of the development of the unicornuate uterus. So that rudimentary horn, if the horn has functional endometrial tissue and communicates with the unicornuate uterus, menstruation won't be interrupted. So this is a unicornuate uterus. We have that one normal horn to the left. And then we can see in this image there's a rudimentary horn here. And it looks like it connects to this rudimentary horn's canal, connects to the unicornuate uterus canal. So the blood, when the patient is menstruating, can flow from that rudimentary horn down through the cervix into the vagina. So there's no interruption there. So if the horn has functional endometrial tissue and it doesn't communicate with the unicornuate uterus, then hematometra will be present because there's no exit. So unicornuate uterus here, nice open endometrial canal, and then this rudimentary horn, we have some endometrial tissue here, but it does not connect. So there's no exit. So if this patient's menstruating, the blood is just going to back up and back up and back up until this patient is in pain or they feel palpable lump in their abdomen. So this can be fixed with surgery. Can open that rudimentary horn into the main canal there. So we're going to look at some ultrasound images of a unicorn uterus. So sagittal, transvaginal ultrasounds. So they look the same in a 2D plane and as a normal uterus in the sagittal position. If you were looking at this image here and this image here, they look the same. So this is the normal uterus, and this is the unicorn uterus. So if you were scanning this unicorn uterus live, you may notice a subtle deviation of the uterus to one side or the other, but that is not really diagnostic of a unicorn uterus. So a sagittal image is not really going to give you the information you need to diagnose a unicorn uterus. So transverse imaging. So this is the normal uterus here, transverse transvaginal. And then we have a transverse transvaginal unicorn uterus. So same as the sagittal image. So they look the same, the normal and the abnormal. So again, if you were scanning this abnormal unicorn uterus live, you may notice a subtle deviation of the fundus of the uterus to one side or the other. But again, that's not diagnostic of a unicorn uterus, as everyone's uterus is in a different position and it could just be a normal thing for this patient. So how do we tell if the patient has a unicorn uterus or not? If you suspect a unicorn uterus, how are you going to figure that out? So this is where our handy 3D imaging comes into play. So this gives us a nice coronal image of the uterus. So we have a normal uterus here, so we can see the myometrium along the outside, so this hypoechoic area. And then in the middle, we have the echogenic area. That is the endometrium. So we can see the endometrium heads out to the left here. This is going to connect to the, the fallopian tube here on the left side, and then same on the right side. So we have two horns. So these two little peaks in the endometrium at the top are the uterine horns. So normal uterus and unicorn uterus. So you can see very obviously that this patient only has one horn to their uterus. So that deviation off to one side, missing the other horn. So 3D is a super handy tool when it comes to diagnosing uterine anomalies, as a lot of them look very similar in 2D imaging. So here we have another nice 3D image of a unicorn uterus. So hypoechoic on the outside here, this is the myometrium, so the muscle of the uterus. And then we have the echogenic endometrium going off to one side, and the other side is gone. So no horn on this side, one horn on the left, so unicornuate uterus. Again, so opposite side here, the horn is on the patient's left side here. So echogenic endometrium, and then we have the hypoechoic myometrium surrounding it. So 3D imaging sometimes gives us what we call chroma, so different colors to the image. Different colors can help highlight different images. A lot of 3D is in this kind of orangey yellow color. Just setting, has to do mostly with settings on the machine. And then this is a 3D image that we call a rendered image. So it makes it look almost lifelike. So we can actually see the vaginal canal down here. So this is opening into the cervix, and then out around here, all myometrium, So a little bit brighter in the middle, and then we have that one horn headed off to the left, and then the patient's right horn is missing. So unicornuate. Rudimentary horns that we were talking about before, they're very hard to see on ultrasound as they're usually very small. So they're usually blocked by bowel gas. I've never seen a rudimentary horn ever. I think they're just something that patients have. Something that patients have relating to a unicornuate uterus, but something that we can't really diagnose just because it's hard to see. So when looking at a unicornuate uterus, we can talk about supplemental imaging. What other imaging can we use to diagnose this uterine anomaly? So a sonohystogram, so that is when saline is injected into the endometrial canal, highlighting that canal. So again, we use 3D imaging when we are doing a sonohyst. So we have the cervix here. We can see a tiny bit of fluid right in that cavity. And then we open up into the endometrial cavity here, the uterine endometrial cavity. We can see endometrial tissue around the fluid, so this echogenic line that kind of borders that fluid. So we see that fluid kind of only going to one side of the uterus. The other side is missing. So this is a unicornuate uterus. We can also see a unicornuate uterus on HSG. So the cavity is seen is highlighted by that radiopaque dye, and then you can see only one fallopian tube fills with that dye. So there's no fallopian tube on the other side. So this is unicornuate uterus. So another nice image, HSG. So this would be the cervix into the fundal body area of the uterus. And then you can see out here this wispy area, that is a fallopian tube. So this whole side of the uterus is missing. So one horn, unicornuate uterus. And this is an MRI image. So this is very similar to the 3D ultrasound image. So this is a coronal view. So we have this darker area on the outside. That is the myometrium, so the muscle of the uterus. And then again, this bright area in the middle, that is the endometrium. So we see it going off to one side here, and then the other side is missing. So this is just one horn to the uterus. On MRI, the uterus has a kind of a characteristic shape, so they call it a banana-shaped appearance. It does look like a banana here. So this is that dye. Not the dye. This is just the MRI picking up the vagina and the endometrial canal. So it just kind of curves this way, looking like a banana. So moving on, bicornuate uterus. So talking about a unicornuate uterus, so uni meaning one, and then bi meaning two. So a bicornuate uterus is when two uterine cornua are fused caudad with communicating endometrial cavities. So the normal cornua, so these are the corners of the uterus, connect and come down into an endometrial cavity here. We can see a nice normal myometrium around that cavity. And then a bicornuate uterus, we can see that one cavity goes off this way and one goes off this way. So this is the part that fails to fuse. So the myometrium we can see dips in. So it's almost as if there are two unicornuate uteri connected, creating a bicornuate uterus. So a bicornuate uterus is something that we call a heart-shaped uterus. So a lot of patients will come in and say, my doctor says that I have a heart-shaped uterus, or I've had imaging before and I have a heart-shaped uterus. So when they're talking about that, they are talking about a bicornuate uterus. So we call it heart-shaped because we have those two echogenic endometrial canals kind of forming a V, and then that myometrium comes down in between those, making that dip, and then the fundus comes out this way. So when you put those two together, it does form kind of like a cartoon heart shape. So here's a couple more examples. So this is just, a drawing of a bicornuate uterus with a fetus. So we have that divot in the middle, that connection of the myometrium, and then where one side deviates out and the other side deviates out. This is a 3D image, so that nice heart-shaped endometrium here. And then we have a pregnancy in a bicornuate uterus again, but just an actual image. So it looks like a heart here. So this anechoic area is the gestational sac, so that's what baby lives in. And then we can see what we call fetal pulse, a very early embryo right here. So bicornuate uterus, looking at it with 2D imaging. So normal, sagittal, transvaginal, midline uterus, and then sagittal, transvaginal, midline, bicornuate uterus. So again, just like unicornuate, they look the same. So you can't tell by this still image if this patient over here has a bicornuate uterus or not. If you were scanning live, sweeping left and right, you may notice two endometriums, so one kind of extending out to the left and one extending out to the right. So transverse imaging. So we have normal, transvaginal, transverse image. So we can see the myometrium, the hypoechoic area, and then the echogenic endometrium in the middle. And then we have the bicornuate uterus over here. So transverse, transvaginal. So myometrium, hypoechoic area. And then we can see those two endometriums here. So this is that endometrium on the patient's left side and the endometrium on the patient's right. So as you scan through, you start with an endometrium that looks like this, so it's connected. And then as you get towards the fundus, it's going to break off. You're going to see two classic endometriums separated from each other. So again, 3D ultrasound is the best tool to distinguish between a bicornuate and a septate uterus. So a septate uterus is kind of similar to a bicornuate uterus, as it has two canals that kind of split off of each other. The only difference is that septate uterus does not have that heart shape, so it doesn't come. The myometrium does not come in between those two endometrium, so it stays kind of straight across here. So they look similar transverse because we're going to get both endometriums here. So this image, you can tell. So you can see these little orange lines here. So this is the plane that the transverse image is taken in. So we can see those two endometriums here. So we can't really tell in a transverse image whether a uterus is bicornuate or septate, but we can definitely tell in that coronal 3D image. So bicornuate uterus, so we can see those two endometriums splaying out and then eventually converging into the one canal. And then we have that dip in between them. So classic heart-shaped bicornuate uterus. Ideally, when imaging a uterine anomaly like a bicornuate or unicornuate, the imaging should be done during the secretory phase of the endometrial cycle. So this is when the endometrium is the thickest and it's the most pronounced. So you're able to see those cavities much better when that patient is in that secretory phase. So supplemental imaging for bicornuate uterus. So HSG. So we can tell that this uterus definitely has cavities that splay to the left and the right, but we can't tell if this is bicornuate or septate, and that's because we can't see the myometrium. So if the myometrium were to come up this way and dip down and follow those endometrial canals, that would be a bicornuate uterus, so that heart-shaped uterus. And if it were, the myometrium would go straight across, that would be a septate uterus. But since we can't, there's no delineation of that on this x-ray, we can't tell if this patient has a bicornuate or a septate uterus. So we can definitely tell with an MRI, as we can see the myometrium. So look at this nice, cute, heart-shaped uterus. How adorable. So we have one endo going this way, one top of the uterus going to the patient's left, and then one to the patient's right. So we have that dip in between there. Okay, so why don't you guys take a break? Try this stretch, kind of get up, shake your legs, get a glass of water. This is a great stretch to do in between scanning. It gets the blood pumping in your legs. If you're standing or you're sitting, your legs can get very tired and the circulation can be compromised if you're standing or sitting in one spot for a long time. So it's good to get that blood pumping into your legs. So take a break, come back, and we'll finish up the rest of the uterine anomalies.